Hey guys, sorry, neurology here. Just like you and I communicate with words and the rest of the body communicate, the hormones are the way that body communicates internally, organs communicate internally, cells communicate via cytokines, but also via things called neurotransmitters, the transmitters at the cellular level. So glutamate, also known as glutamic acid, is an amino acid that is the most common excitatory neurotransmitter. As the name says, it excites, activates, stimulates all the cells that it acts on. It also does sometimes inhibit, but that's irrelevant. Most of the time, it's stimulating. So what it does to the cell, to the neurons, when it talks to them, it says, hey, do your work more and more and more. All right, now what happens when we have increased levels or super toxic levels of this neurotransmitter? Then this activity that glutamate is trying to cause increases multiple folds. And so what we have is we have an influx of sodium and calcium that would have normally taken place, but now it's not just one time, it's like so many more times than a cell could tolerate. Cell is activated, extremely activated, and also because of too much calcium, now the so-called death enzymes that are part of apoptosis and necrosis actually are activated and cause cell death. Molecular level, not sure you need to know it very well, but now you know it. You do need to know the terms, and this is important in stroke. That's why, because stroke is something that the science and research is working on. That's what this whole molecular information is all about. Now, you do need to know the clinical terms very well, the paresis, and we saw this paresis earlier. And I told you that paresis is like partial paralysis. So paresis is much smaller than paralysis. It's just a definition. Now you can have a hemiparesis. Hemi means half. So paresis of only weakness. That means weakness of only half of the body. We don't say hemiparalysis. Hemiparalysis is not really used, but we do say hemiplegia. That's the term that you know. All right, now let's move on to stroke. We have ischemic stroke and we have hemorrhagic stroke. All right, so what's the difference? Ischemic stroke is when there is an ischemia, blood doesn't flow to a certain part of the brain. This can be caused by atrial fibrillation, carotid stenosis, any blood vessel, brain blood vessel, cerebral arteriosclerosis. In our atrial fibrillation, what happens is that the heart doesn't pump very well, um, and so there is a formation of thrombus due to stasis of blood, due to or due to some hypercoagulability and or endothelial injury. You know the story of Virchow's triad from week 3. And so this thrombus flies, which and now we call flies toward wherever blood is going. So now it's no longer called thrombus, it's called thromboembolism. And this thrombus now eventually hits a blood vessel that's too small to accommodate it, and it can't continue its travel as an embolus and blocks, and now it can block off, cut off the circulation. Blood doesn't flow there anymore. That's called ischemia, and therefore we call it ischemic stroke. The principle is exactly the same as in the myocardial infarction. Therefore, we sometimes call ischemic stroke a brain infarction. This is a good point, the good time point to review DVTs, deep venous thrombosis, with stasis, hypercoagulability, and endothelial injury being the triad that causes thrombus formation as per Virchow. And in the pulmonary circulation, it may cause, for example, pulmonary embolism and damage to the lungs, and maybe even cor pulmonale and sudden death. Now, sometimes these emboli are very, very, very small, and not only very small, but also can degrade quickly. So what happens then is we call them, they're essentially temporary, right? So this cutting off of circulation is temporary, and therefore another word for temporary is transient, comes and goes. So we now call it an attack on the brain that is transient. But what kind of an attack is that? That's an ischemic attack. So transient, there is a transient cutting off of blood circulation, and therefore we call it transient ischemic attack, which is obviously temporary cutting off, decrease of blood flow to a particular area of the brain. And sometimes we call these hypoxic, meaning that there is a hypoxia in that area, and ischemia in that area, and we call them hypoxic ischemic or ischemic hypoxic events. So they result in transient ischemic attack. These resolve on their own, and there is no death of the tissue. That's very important, and this is what distinguishes it from the stroke. This is not an ischemic stroke. This is totally okay, but in some cases this may be a warning. Hey, a stroke may be coming. Hey, take care of this patient. Have a special look at where this thrombus came from. Now, you need to understand that in stroke, only the area that is affected in the brain will manifest in terms of symptoms. So, for example, if it's the occipital lobe, which is normally responsible for vision, that's affected, patient would have problems with vision. If it's the temporal lobe that's affected, that's normally responsible for hearing and memory. It's going to be hearing and memory that are clinically, that the patient will present with in terms of clinical problems. If it's the parietal lobe, it's the sensation. If it's the frontal lobe, it's personality changes. If it's cerebellum, which is responsible for balance and movement, then balance and movement are going to be affected. Clinical presentation depends on the area affected. Nothing else is affected. We rarely ever get anoxic encephalopathy, meaning like the whole brain there is a disease of the whole brain with anoxia, no oxygen to the whole brain, hypoxic ischemic brain injury to the whole brain. That doesn't happen very often. Cessation of blood flow to the whole brain would be causing a sort of a quote unquote ischemic stroke to the whole brain. That doesn't really happen, but when it does, you're talking about decrease in consciousness as a matter of fact. So when there is a stroke, there is an area that is definitely unable to survive, because brain cells start dying after about 3 minutes of no oxygen being supplied to them. So this area is going to die for sure. Now around it, there is a smaller area that may potentially be saved, that relies on the same blood vessels that this artery, this damaged area relied on, but also has some supply from the outside. So this area is the area that we call ischemic, because it does have decreased blood supply. Remember, we blocked off this vessel, and therefore we have apoptosis and necrosis of this area. We have a stroke, ischemic stroke to this area. And we call it ischemic penumbra. What is very important is that this area can potentially be saved, but it's a very narrow area and can only be saved if the person is treated very, very quickly, if we take an action very quickly, because the dead tissue essentially is like a tsunami. It starts this Excitotoxic, the the term that we used earlier, excitotoxic damage, kind of spreads from this dead area, necrotic center, outwards. And so we have very, very short time where we can actually save this area called ischemic penumbra, and only if treated very quickly. Now, let's compare this ischemic stroke, and don't forget, transient ischemic attack is not an ischemic stroke. In ischemic stroke, we have a part of the tissue that dies that is surrounded by ischemic penumbra. Now, let's compare this ischemic stroke to a hemorrhagic stroke, in which one of the examples would be a rupture of an aneurysm that injects subarachnoid space in the brain with blood, and we call it subarachnoid hemorrhage. Now, obviously, this is going to cause hemorrhagic stroke at first, just for you, because you guys are going to be doing clinical work later on. This also causes, as a double whammy, it also causes ischemic stroke later on, because for some reason all this blood constricts the blood vessels after a few days, and we do have to treat these patients for ischemic stroke prevention as well. But initial damage is the hemorrhagic stroke. Hemorrhagic stroke results in hemorrhage, is due to hemorrhage. This hemorrhage results in blood leakage. The blood pools together. We call it hematoma, and obviously takes up space. Now, you know that a brain is contained in the calvarium. This calvarial space is very, very limited, and so the pressure in the brain rises, in the head rises very quickly, and what we see later on is a triad or a reflex called Cushing's reflex, and I went over this in class, but just a reminder, we have initial hypertension followed by bradycardia, followed by irregular respiration, and if nothing is done about it, there's very likely going to be a brain herniation. Cushing's triad, Cushing's reflex, is not the same as Cushing's syndrome and Cushing's disease. All right, now neuronal death is not always due to hypoxic ischemic events. Loss of neurons in Parkinson's disease, for example, has another pathophysiology. There is a progressive loss of neurotransmitter called dopamine. Parkinson's is spelled as PA, first two letters. Dopamine has PA in it too. Just remember Parkinson and dopamine. Patients with Parkinson's disease have a progressive loss of the neurotransmitter called dopamine. It's not the neurotransmitter called that we discussed earlier, called glutamate. This is neurotransmitter called dopamine. All right, so, and the location where this happens is in the midbrain, in the part called substantia nigra. Now let's talk about two diseases, one in the CNS and one is in the PNS. PNS stands for peripheral nerve system, and CNS stands for the central nervous system. And we're going to be talking about myelin, which is a protective sheath, myelin that forms a protective sheath around axons in both the CNS and PNS. Myelin in CNS is made by oligodendrocytes. These are the glia cells of the CNS. Myelin in the peripheral nervous system is made by Schwann cells, peripheral nervous system Schwann cells. Now, those two cells are very different, and what really matters to us right now, you know, you've studied them in your anatomy courses. What really matters here is that in multiple sclerosis and in Guillain-Barré syndrome, we have the difference is that in multiple sclerosis, we have a damage to the CNS myelin. Myelin is attacked by autoreactive T cells and autoreactive B cells in tandem, one after another. And so there is a myelin damage. When myelin is damaged, there is a demyelination. Myelin is essentially a damage, right? So it doesn't exist anymore. And so this too can target any CNS area. But didn't I just say CNS? So we're talking about CNS, multiple sclerosis, CNS only. Signs and symptoms obviously depend on the damaged area, just as in stroke. And you can review this video and memorize all of these because they're going to serve you for a long time, even for your NCLEX. All right, so in peripheral nervous system damage, it's a little bit different. First of all, we don't call it multiple sclerosis. We call it Guillain-Barré syndrome. Some people call it Guillain-Barré syndrome. And what you're going to see is that after infections, usually noted after, for example, Campylobacter infections, a bacterium, we see an acute, but there are many types of Guillain-Barré syndrome, just so that you know, okay? And so there is an acute happening right here, right now. Demyelination, we've already seen this word before. It means myelin damage. It's associated with myelin damage of peripheral nerve axons, and we also see inflammation. So just remember these two. Just remember these two terms: Guillain-Barré and multiple sclerosis. Multiple sclerosis, CNS. You do need to know two more terms. Epilepsy, which is a neurological disorder. So we define the disorder epilepsy as recurrent and unprovoked disorder of recurrent, that means they happen again and again, and unprovoked, no cause, we don't really know why, seizures. We do know from EEGs, electroencephalograms, and after observing electrical activity, that there is actually a problem with ion channels. We already discussed the ion channels of glutamate receptors when I just started. Basically, there is some kind of a problem. It's not just glutamate receptors, it can be anything else. So there is a malfunction, and depending on what channel and what area is malfunctioned, we have various types of epilepsy. You do need to know that there is that there are many types of seizures. Okay, seizures can be very localized. We call them focal or partial or generalized. And focal or partial seizures occur when this abnormal electrical activity is limited to a certain area of the brain, and usually we say it's one hemisphere, only one half hemisphere. If you think that the brain looks like a ball, then half of that brain, half of that ball. So a partial seizure is limited only to one hemisphere, or to a hemisphere. All right, now let's talk about headaches. Headaches generally occur more often in females than in males. There is one type of a headache that is an exception that occurs more often in males than in females. And this headache is called trigeminal autonomic cephalgia. If you break down the word cephalgia, algos stands for pain, ceph stands for head, so headache. So this is abbreviated as TAC, T-A-C, and the most important type of TAC headaches, trigeminal autonomic cephalgia, is known as cluster headache. Cluster headache occurs in cluster. It occurs between 15 minutes to 3 hour multiple times a day, and it's called a suicide headache because it's so severe, and people have often expressed their opinions saying that this is the most the most painful experience that a human can actually undergo. Now, what you need to notice is that the name carries the name autonomic, and you need to remember that autonomic symptoms always are always a part of the presentation of this headache. And what are the autonomic system? these are the symptoms which you see as a part of the autonomic nervous system. In the eye, it would be a tearing, i.e., lacrimation, and due to inflammation, for example, or drooping of the eyelids. Okay. In the nose, you know what autonomic symptoms are. That would be rhinorrhea. Your nose, you're going to have a runny nose, rhinorrhea, or congestion. All right. So just remember, these are unilateral headaches that are extremely severe, and they're related to the trigeminal nerve.